first through fourth year med students. So I'll briefly kind of just talk about what a spinal cord injury is. I'll talk about how we assess that using something called the ASIA exam. I'm going to talk about just some common secondary complications that are associated with spinal cord injury, briefly talk about how we can manage some of these things. And at the end, I'll kind of tie in some stuff as to just some recent advancements in the field of spinal cord injury in terms of caring for people both as an inpatient as well as an outpatient. And then give me 1 second to get my screen shared. Justin, I think you might have to accept my screen share thing.
Let's see here.
I think it works now. You can try to share the screen.
Can you see my slides?
Yeah, we can see them.
All righty. All righty. So we kind of already went over that stuff real quick. So real quick, just some learning objectives, kind of briefly already talked about this, but this is the plan for today. SCIM is just talking about spinal cord injury medicine. So SCI, spinal cord injury, SCIM is spinal cord injury medicine, in case you see that kind of pop up throughout the presentation. All of these kind of individual topics that we're going to talk about today, honestly, they could all be an hour lecture on their own. So I'm going to give a very kind of broad, superficial overview. I'll leave some time at the end for questions. I'll try to get done at around 7:40, 7:45. And if you guys have any questions, you can throw them in the chat and I can answer them at the very end. Or we can just kind of, rifle off questions at the end. So briefly, just some epidemiology about what a spinal cord injury is. So paraplegia versus tetraplegia. That's a big distinguishment that we want to make. So paraplegia is basically some kind of lesion to the spinal cord where the cervical spinal cord is spared. So paraplegia commonly will only really affect your legs, while as tetraplegia can affect your arms and your legs. So paraplegia is no cervical spinal cord involvement. Tetraplegia does have cervical spinal cord involvement. And you have this notion of complete versus incomplete injuries. So a complete injury basically means whatever your level of injury is. So let's say you're a T4 spinal cord injury. If you're a complete T4 spinal cord, you have no motor, no sensory function below the T4 dermatome. Whereas if you're an incomplete spinal cord injury at T4, that means you have some degree of either motor or sensory preservation below that level of injury. In terms of prevalence, so you have incomplete tetraplegia followed by incomplete para, complete tetra. That's from most to least prevalent. That's something they might ask you on like an elective rotation. That's the other thing. I'll try to kind of point out some things I think are important for med students for you guys if you're looking to do like audition rotations and electives and stuff like that coming up. In terms of traumatic versus non-traumatic injuries, traumatic injuries I think speak for themselves. That's something like a motor vehicle accident, violence, or a fall. A non-traumatic injury, those are becoming much more common now. So those can be things from malignancy. If you have a tumor growing somewhere into the spinal cord, you can have an infectious cause from that. Things like that. Radiation-induced myelopathy, that's also a thing. So traumatic tends to be a lot more common than non-traumatic, but non-traumatic is gaining in terms of the prevalence numbers. And the other thing I wanted to highlight on this slide is just at the age at the time of injury. So very young age, 43 years. So the big thing with spinal cord injury years ago was that we didn't know a lot about it. So people would initially have this injury and they weren't expected to live a very long time. But now they're having these injuries at a very young age and they are living a very long time. So now we're learning about all these comorbid health conditions that come specifically from a spinal cord injury. And that's kind of why we have this concept of spinal cord injury medicine now, where we are caring for people longer into life and really kind of speaks to the role of the growing role of the physiatrist in caring for this patient population. Briefly, what is a spinal cord injury? So I'm not going to read the definition off the slide, but there's some level of weakness, sensory abnormalities, reflex changes, and autonomic dysfunction associated with this. I really like this picture here. In the next couple of slides, I'll delve into this, but I think that the best way to think of a spinal cord is that, first off, it's obviously connected to your brain, but think of it as this connection of cables. So think of it as like a highway with all these roads, and that's kind of how your body communicates. Your brain communicates with the rest of your body. So for the next couple slides, I just want you to think about this image right here. So we're going to hone in on that area in the blue box that really bright white hyperintense area is going to be damage to the spinal cord. The black substance that white lesion is in, that is your actual spinal cord. The white stuff around that is just your CSF and your fluid. So again, highlighting that hyperintense bright area, this is kind of what we see here. So it's a cartoon version of a spinal cord injury. So you can see in the middle, you've got the circle with the zone of initial damage, right? So you have, let's say, you're in a motor vehicle accident, your vertebrae, jettisons back and it hits your spinal cord. Zone of initial damage, that's where we're at. Right after that, we have the cyst form around the spinal cord. Not even pictured on this slide, you have this entire secondary enzymatic cascade of injuries that occurs that also kind of influences how you can respond to a spinal cord injury. And you can kind of see here, so you have all the myelin. Can you guys see my my mouse or no? You can? Okay. So you can see like the myelin here. You can see here where you have the spinal cord injury, you lose all of that myelin. So all those cables that we had just been talking about, they're now disrupted. And that means you have disrupted communication from your brain throughout your spinal cord, throughout the rest of your body. And again, kind of looking at those cables. So those cables don't just go to muscle and they don't just go to nerves. They go to a lot of other things. They go to basically every organ in your body. And that's kind of how your body kind of, maintains homeostasis and communicates with itself. So now I have this disrupted track of communication that goes to muscle, your nerves, your heart, your lungs, your endocrine system, and it can lead to all of these secondary complications that you can see here. Pneumonia, I've got highlighted in green just because if anyone ever asks you what the primary cause of death is in spinal cord injury, usually it's respiratory related. Chronically, that's going to manifest as pneumonia. Acutely, that can manifest as something like a PE. And again, that's going to be a lot more prevalent in people that have cervical spinal cord involvement, because if you guys remember, C3, C4, C5 keeps the diaphragm alive. You can't clear those secretions, things like that. You build up mucus. That's a breeding ground for infection. Some of these other complications we'll talk about kind of as the lecture goes on. So ASIA exam, what is it? Basically, it is a universal, it's a worldwide standardized measure that we use to track progress with spinal cord injury. To be completely honest with you, it can be very time consuming, particularly in an acute care setting when you have someone coming in who's likely in a traumatic accident and they have a ton of other injuries that need to medically stabilize. The literature will tell you a bunch of different things as to when these exams need to be completed. In general, you want to have your initial ASIA exam done for someone with a spinal cord injury, usually within 24 to 48 hours of their initial injury. The important thing you want to remember for that is that there's this concept of spinal cord shock after anyone has an injury. So you're going to be completely flaccid below what your level of injury is. So you're not going to get any reflexes. You're not going to have any motor sensation. You're not going to have any sensory sensation. And the idea is that you want to wait for this kind of spinal shock to wear off so you can get a more accurate assessment as to what this person's potential new neurological baseline is. And that's kind of the idea of getting an ASIA exam done very quick, is you want to establish what their neurological baseline is. The ASIA exam basically allows us to kind of universally have a language that everyone can use to communicate with as to how we can establish that baseline. So you want to get the first one done usually 24 to 48 hours in the acute care setting or whenever they're out of spinal shock. Then ideally what you would want to do is you would have one done right before someone transfers to acute rehab. And then you would ideally want to have one done right before they leave acute rehab. And then it's usually every 3 months, 6 months, 9 months at 1 year. And then ideally after that, you're in the chronic phase of spinal cord injury. You want to have it done every year. And I'll explain why that's super important at the end. Is because recovery after a spinal cord injury, we used to think that it was kind of, within like the first year or two, whatever you have that's it. That's kind of whatever function you're going to get back. And to some extent, that is still mostly true. But a lot of the newer research that we're finding now is that you can actually have motor recovery, sensory recovery years down the road after a spinal cord injury. But we'll touch on that at the very end. And you can kind of see here this exam. So you have your motor columns on the side, so C5 to S1. We'll talk about that in the coming slides. And then you have your sensory columns in the middle. Just keep those in mind when we the next couple slides. But these dots that you see here, just kind of on the figure, those are where you're going to do your sensory assessment. And again, these are done worldwide. Everyone does it at these same spots. They basically correlate to certain dermatomes on your body. So what three things does the ASIA exam consist of? So you have motor testing, you have sensory testing, you have rectal tone and sensation. I have individual slides coming up with that, so we'll kind of hit on those there. But the three things that it tells us with those three different categories is it tells us our motor level of injury, which is going to be your most distal spinal cord segment that is at least 3 out of 5 strength on manual muscle testing, so at least anti-gravity, and everything above that has to be 5 out of 5 strength. So it's basically the most distal dermatome that's at least anti-gravity. Everything above it is 5 out of 5. Sensory level of injury, so that's going to be your most distal dermatome that has fully intact light touch and pinprick sensation, and everything above that is also fully intact. And your neurological level of injury, the easiest way to think of that is that's like the caudal, so the most towards your head level of injury. It's going to be the most serious level of injury, and that's kind of what people will commonly kind of refer to as what their spinal cord injury is. So if you're T4, ASIA A, B, C, or D, that means your neurological level of injury is a T4. For anyone that's going to be like going into 4th year and doing elective rotations, and if you're lucky enough to get like a really good spinal cord rotation, I think just knowing what the ASIA exam is and what the different components of it are is more than enough. I know there's like some gunners out there who want to go in there and know how to do a full ASIA exam on day one. It's tough even for brand new like PGY2 residents just because there's so much that goes into it. So I think just kind of having a really good understanding that it's this universal tool that's used to assess spinal cord injury is important. This is kind of what comprises it. And I think knowing how to do it is very important, and kind of how to obtain the data is good. I don't think necessarily worrying about have to calculate the score is super important, although it's not terribly hard. So manual muscle testing. So again, this is like your normal muscle testing that you'll learn during your basic years of med school. The one important distinction that I will make for the ASIA exam is there's no pluses or minuses. So it's you're either a 3. You're not a 3+. There can't be a 3-. You're either 0, 1, 2, 3, 4, or 5. And just a helpful hint for anyone who's having trouble in terms of trying to remember how to make sense of 0 to 5. 0, no muscle activation. 1 is you're basically palpating to see if you can actually feel the muscle activate. So if you're feeling for like hip flexion, you're going for the iliopsoas. 3 out of 5 is your full active range of motion on your own. So what that means, if I'm having somebody pick their arm up on their own, that means they can pick their arm up all the way on their own without needing any physical assistance. That's what active range of motion is. If you can at least do that, your full range of motion, you're at 3 out of 5. Then after that, it's just applying resistance. So if I can basically break you when you bring your shoulder up, you're a 4. If I can't break you, you're a 5. And then 2 is not having full active range of motion. Light touch sensation in terms of the ASIA exam. So the one thing I'll say is we use a very fancy tool here. We use a cotton swab. The one thing that's important is you want to compare that to your face. So you need to give people a baseline. So the cheeks is very common. So that's always going to be normal in someone with a spinal cord injury, just because C2 is as high as you can really go in a spinal cord injury. And C2 is obviously not going to innervate up here in the face in terms of a spinal cord injury. So face is always assumed to be normal. So you just test them on the cheek, and you would basically take the cotton swab and you put it on the cheek and you say, can you feel that? And you say, yes. Ask the person to remember what that feels like. And that's going to kind of be their reference for every other dermatome that you test. Then you're kind of going down the dermatome based on that sheet, identifying very select spots. And you're asking them, I like to tell them, I keep it very simple. It's like, can you feel this? And just tell me, does it feel the same or does it feel different? If it feels the same, you score it as a 2. Same meaning it feels the same on your shoulder as it does on your face. That's going to be a 2. If you feel something, but it feels different, whether that means you feel less of it or you feel more of it, that's going to be a 1. And if you feel nothing, that's a 0. Not testable, you would use, for example, if somebody has like let's say they have a full arm fracture or something like that, and they're in a cast and you can't test that specific dermatome, you would just put not testable for that. And then you can see here on this slide, this box here on the side, the comment section, any kind of exceptions to when you're doing your testing, you would just list it there. So that's light touch. Pinprick, you basically do the exact same thing. You're just using a safety pin. We like to call it the poor man's MRI. So again, the other thing they might ask you as a med student is what do these different sensations, what tracks are they testing, right? So you have pain and temperature, which is going to be spinal thalamic. So that's going to be more like pinprick. That's what we'll be using here with the safety pin. And then your dorsal columns will be more with the Q-tip. But they love to ask med students that, so just a heads up. Rectal exam. So this is going to be the third component of the ASIA exam. You're getting two different things that you're testing with this. So you're testing deep anal sensation, aka rectal wall sensation, and you're testing rectal motor function. So deep anal sensation, you're putting your finger into the patient's rectum. Always use a lubricant, obviously, and a glove. I use a double glove. You're putting your finger up against the wall of their anus or the rectum, and then you're basically you're moving your finger up, and you want to give them a reference on this. So you'll point your finger up. You'll say, this is up, you'll point it down, this is down, you'll move your finger back to the neutral, and then you'll kind of go up or down and ask the patient, is it up or is it down? And you'll kind of get a sense of if that's intact or not. Rectal motor function is you're just same thing, finger goes into the rectum, and you ask the person to kind of clench down. You'd say, the thing that we like to tell people here is if you're at a dinner party and you're sitting in the middle and you really have to go to the bathroom and you have to bear down because you think you're not going to make it to the restroom in time, do you think you can do that right now? Ask them to do that on your finger. If you can feel them contract onto your finger, that means rectal motor function is intact. If you don't, that means it's not. The important thing with that is you do want to check to make sure, put your finger in and give it a second to kind of wait. You'll get a spasm a lot of the times, especially if they have an upper motor neuron lesion. So that's something you want to distinguish between a spasm and then the sensation being intact, just because basically if you have sacral sparing in the rectum, that's really the difference between being a complete or a non-complete spinal cord injury a lot of the time. And that has a lot of implications as to what the goals are during rehab. So just something to be aware of is that initial spasm. This is kind of my quick and dirty way how I like to cheat on the ASIA exam. It's probably a little bit way too in depth, but the way I like to break it down is you have ASIA A, B, C, D, and E. E is basically normal, but the important thing to know is that means you have previously had some kind of a documented spinal cord injury. So just because you have fully intact motor and sensation throughout your body, that doesn't mean that you're an ASIA E. You have to previously have been somewhere on the spectrum of ASIA A to D and have recovered to some extent to be fully normal now to be considered an ASIA E. The big thing here, which you can kind of see with the dotted line, so no voluntary anal contraction means you're an ASIA A or a B. That's kind of how I like to break it down in my head. If you have no voluntary anal contraction, the highest you can be is an ASIA B. After ASIA A and B, that's going to be intact. And then you just have different varying levels of motor and sensory preservation below the level of injury. ASIA A is the worst. There's the one test in life you don't want to get an A on. ASIA D is theoretically the best. So ASIA C's and D's, we usually see very good outcomes in terms of if your initial ASIA exam is an ASIA C or a D, usually you're going to be much more likely to convert, meaning you'll go from an ASIA C to an ASIA D later on at like 1 year, which obviously means you're improving. If you're an ASIA A or a B, those are the ones where you're a little bit stagnant. You're not going to progress as much with therapy. Not to say that you won't progress, it's just a lot more difficult and it's a little bit more rare. But I think with a lot of the emerging therapies that are coming out now, I think that we'll hopefully see a lot more of those conversions in the future. So that's kind of it for the ASIA exam. I'm going to briefly talk about secondary complications. So this slide and the one kind of talking about all the organ systems that are affected by spinal cord injury, I think that is, in my mind, what makes spinal cord injury to me so interesting and kind of cool. I always liked medicine. I think that being an internal medicine doctor for me was just way too much. I think it's way too much getting lost in the weeds. Being a spinal cord injury doctor, even a physiatrist, I think that you get to do a lot of that medicine, but you're not going to do too much of it where you feel like you're just a straight up hospitalist. And for me, that was at least very important in my career. And the other thing that's nice about it is there's very specific things that, a physiatrist is a specialist, right? That's why our residency is 4 years. There's very specific things that we are trained to treat that other people don't even know about. So for example, neurogenic bowel and bladder, that's one of the things that you'll treat in everything. It's not just unique to spinal cord injury. I have a brief slide on that coming up. Orthostatic hypotension, autonomic dysreflexia. AD is very common and unique to spinal cord injury. OH can obviously be prevalent with a lot of neurological things like Parkinson's disease. Heterotopic ossification, you can also see in like stroke patients and brain injury patients. It's very common in spinal cord injury patients. The most common place you'll get that is in the hip for spinal cord injury patients. And if they like to ask you, where's the most common place that you'll see that in a pediatric patient? It's always the elbow. What is HO? Basically, it's bone forming in places where bone shouldn't be forming. So you can see here on the image that I have, you have this X-ray. It's going to be your femur up top. Right here, you can see on the outside what these white arrows are pointing to. That's going to be some bone matrix being deposited. And the way I like to think about this is it's very common below the level of injury. And why does it happen? We don't fully understand. But what I like to kind of tell patients is that you have these, mesenchymal stem cells that are responsible for, forming bone. Basically below the level of injury, because those cable network is a little bit, it's broken. Those stem cells get confused and they start to put bone where bone shouldn't be. And that's why you get this. And HO, it can be a problem for multiple reasons. I think that one, it can be very painful. That can be interpreted as, it's a painful stimulus for a body. It can precipitate autonomic dysreflexia. It creates very bony prominences at places where you normally bear weight. So for example, on a spinal cord injury for someone who has no sensation, you're now getting these very pointy, bony prominences on the sides of your hips. That can lead to skin breakdown, which is obviously a problem. It's even more of a problem with spinal cord patients because they can't feel that. Pain, spasticity, not unique to spinal cord injury, but it's very, very common. Briefly, just want to talk about autonomic dysreflexia. So this day will 100% ask you, so what level is it most common at? Is going to be T6 in anyone with a spinal cord injury. The reason for that is that's where your sympathetic chain is. So T6 and above, you're at risk for spinal cord injury. You can still get it if it's below that level, but it's going to be most common at T6 or above. They may, if they really want to kind of try to test you, they'll ask you, where is temperature regulation regulated at? So autonomic dysreflexia, we're always taught to think about it as autonomic 6-reflexia, T6. Temperature regulation is going to be at T8. And people with spinal cord injury do have impaired temperature sensation. And I remember the first traumatic spinal cord patient I had here at Tower. He was actually in the room and he was just sitting there and he was super, super cold, but the temperature was cranked up to like 70 degrees. And that's because you get impaired vasoconstriction below the level of injury. Your skin can't sweat as much. It can't constrict. And that's also why you get a lot of blood pressure abnormalities, which is basically what autonomic dysreflexia is. So what I want you guys to think about is you have your level of injury. So you can see right here, T6, again, thinking about the spinal cord as this network of cables. Below that level of injury, you have some kind of stimulus that your body interprets as pain. Usually it's going to be a distended bladder, right? So you have a distended bladder, your body interprets that as pain. Those sensations going up the spinal cord to your brain, they're intact. So your body can sense that this is happening, but that you'll have a local sympathetic response because of that. So because of this local sympathetic response, you're going to get hypertension, which makes sense, right? Blood vessels constrict, you get hypertension. The problem with autonomic dysreflexia is when you can see here these red channels, when they're coming back down, that inhibitory stimulus is blocked. So now you cannot stop that local vasoconstriction. Your body basically tries to compensate via the vagus nerve, and that's how you get bradycardia. So those are your two hallmark kind of signs of autonomic dysreflexia. You have hypertension and you have bradycardia. You technically can have tachycardia, but classically it's with bradycardia. And this is important to distinguish because, again, with spinal cord patients, you get orthostatic hypotension, right? So with orthostatic hypotension, you're going to have low blood pressure. Autonomic dysreflexia, you have high blood pressure. And then to add in kind of another twist to that situation, spinal cord injury patients have a lower baseline blood pressure than someone without a spinal cord injury. So ideally, 120/80 is great for somebody that does not have a spinal cord injury. It's very common for people with a spinal cord injury to be sitting at around the low 100 systolic. So that can be an issue because if you have a spinal cord patient who's sitting there and they're 125, 130 systolic, that's technically, they could be an autonomic dysreflexia now. And that can be it can be life-threatening. You can have seizures, you can have a stroke, you can have myocardial infarction from things like that. So it's something you want to be very vigilant about. It's something that you constantly want to be educating people who are at risk for it, what it is and kind of what the signs and symptoms are. What are some of the signs and symptoms? And actually, I don't have a slide on that, but again, hypertension, bradycardia, you can get a lot of like piloerection above the level of injury. You can have sweating and skin flushing above the level of injury, whereas below the level of injury, you're basically going to have nothing. Your common causes, so another saying that we kind of like to have is number one most common cause is number one, your number two most common cause is number two, number three is everything else. So number one is going to be a distended bladder, number two is going to be distended bowels, number three is going to be everything else. And just kind of a quick outline as a treatment for this. So First thing you want to do if you suspect autonomic dysreflexia, you sit the patient up, just because if they're leaning forward, you're going to be more at risk to raise blood pressure and theoretically precipitate like an aneurysm. You want to check the clothing, make sure it's not too tight, make sure it's not causing a painful stimulus. After you do that, if the blood pressure doesn't resolve, you want to quickly do a cath their bladder, because again, bladder is the most common cause. And then after that, you inspect the skin for any potential skin lesions. And then you would theoretically want to evacuate the bowels. In terms of treatment, you have nifedipine, clonidine, and nitro paste. Those are the three. Nitro paste is a last resort. That's something you just put on the forehead. You want to make sure you're wearing a glove while you do that. That'll really kind of tank their blood pressure very fast. That is AD. I'll talk really quickly about neurogenic bladder. Again, this is something that honestly you can give like a 2-hour lecture on. Really what the goal of treating a neurogenic bladder is someone with a spinal cord injury is again, think about these people getting injuries at a very young age. You're a 40-year-old man or woman, you have a spinal cord injury, you're going to live another 25, 30 years. Hopefully, you want to preserve their renal function. So a lot of the times people can't void on their own. So ideally, you want to, you always go from least invasive to most invasive in terms of treatment for anything, not just with spinal cord injury. First thing you want to do is behavioral modification, so time voiding. Maybe you get some of those reflexes back that allow you to void. Then you can start to add pharmacological intervention. Things you want to be careful of with that is that a lot of these medications can also affect your blood pressure. And as we've kind of talked about, OH, autonomic dysreflexia, they're going to have baseline blood pressure problems to begin with. So ideally, you don't have to use meds, but a lot of the time we do. Clean intermittent catheterization is really the gold standard in terms of people who are not able to void on their own due to their injury. So what that basically is, if anyone doesn't know, it's assuming the patient has intact hand function, you're taking a catheter, you're inserting it into your urethra, and that is basically going to have your bladder just reflexively drain on its own. If they ask you what bladder volume you want to do, usually you want to have someone cathing themselves 4 to 6 times a day. And the number that you want to keep that volume at is about 500 liters of urine. The reason you want to keep it that low is if it gets higher, you start to get reflux urine up your ureters, up into your kidneys, and that can cause kidney scarring. That can lead to higher incidences of cancer. That can lead to sepsis. It can lead to higher urinary tract infections. So if you're having somebody cath and they're basically cathing out more than 500, you want to increase the amount of times that they're catheterizing just to make sure that those numbers get smaller and smaller and smaller. The other thing that you want to look for with this is, I'll highlight, is urodynamic studies. This is something I think nobody gets exposure to until you get to like a fellowship level. Maybe if you're doing a residency somewhere that has, a urologist that does this stuff or a spinal cord injury doc that does this. Basically what that is it's a procedure where they kind of instill fluid into your bladder and they can tell what the problem is with your bladder. So again, your bladder contracts, your urethra has to relax in order to void urine. So I talk with my hands a lot. So if your bladder contracts, but this isn't contracting, you're contracting urine, it's just going to reflux right back. So urodynamic studies basically allow you to say, is a problem here or is a problem here? And that's very important because depending on if it's the bladder not contracting or the sphincter not opening, there's certain medications you ideally want to use for that. So urodynamic studies are important to basically obtain at least once right after a spinal cord injury. And then ideally you kind of follow that over time to make sure that everything is working properly. Neurogenic bowel, same thing. You need to distinguish, is it an upper motor neuron or a lower motor neuron? The reason for that is the treatment for them is very much different. If you have an upper motor neuron bowel lesion, you can utilize the reflexes that I have here. So your gastrocolic reflex is basically anytime you have food in your stomach will naturally open up. When your stomach naturally opens up and expands, that basically you can stimulate reflex defecation by doing that. So if you're an upper motor neuron, that's something that you might want to consider taking advantage of to help facilitate normal, regular, everyday bowel movements. It's rectocolic reflex. That's basically sitting on the toilet after there's stool in the rectum. It'll expand the rectum, and that'll again be reflex voiding where you can have a defecate reflexively. But those are only intact in upper motor neuron bowels. That's a very important distinguishment to make. In lower motor neuron bowels, those reflexes are not intact. So a lot of the time you're playing this game with the medications down here, like stool softeners, laxatives, prokinetic medications to get the optimal stool consistency to hopefully take some advantage of those reflexes if they're somewhat intact. If not, it's basically manual disimpaction. And that's why a lot of these medications, for example, they're over-the-counter medications, but they're very important to keep track of stool consistency in some of the spinal cord injury, because if you do too much stool softener and now your stool is going to be too liquidy, that can impact how long it takes to do a bowel program. So just kind of important considerations. And the other important thing to consider here is usually if someone doesn't have intact hand function, they need to have like a family member or caregiver, somebody help them with this bowel program. So your goal is basically to have, one bowel movement at a predictable time every day for somebody with a neurogenic bowel. So whether that be first thing in the morning, last thing at night before bed, you want to make sure that you're doing everything you can to facilitate one a day at a predictable time, and you want to do it in a very quick manner. So those are kind of the goals of what a bowel program is. And I'm running short on time, so I gotta speed up. So real quickly, I'll talk about some advancements in spinal cord injury care. This is just some stuff I saw in elective rotation I did down at Kennedy Krieger and John Hopkins down in Baltimore. I saw a lot of stuff I had read about before, but seeing this stuff in person is very cool to see, and kind of did some research in it as to understanding why this stuff works. And I would encourage all of you guys, not just when it comes to like PM&R, but anything in medicine, you need to know why. If you don't know why something works, you really don't know anything about it. And I think as a resident, that's something that is going to be very important, because in PM&R, and especially in spinal cord injury, patients are going to want to know why they're doing things. It's going to be very hard to sell somebody to do a 25 or 30-minute bowel program every day if they don't understand why they need to do it. So just things to keep in mind. So I'll talk about ABRT real quick. So activities-based restorative therapy. So this is basically the concept that you can have neurological return of function at any point after your injury. So again, 2 years is kind of what you got at 2 years is more or less what you're left with after a spinal cord injury. However, using things like ABRT, which is this principle of putting basically having stimulus above and below the level of injury, facilitates more communication between those cables. Those cables are now allowed to communicate better. That means they're more likely to reattach. The trick with that is always making sure they reattach correctly. And a lot of time when they don't reattach correctly, that's when you get stuff like spasticity, for example. But this concept of ABRT, it's not rocket science, it's exercise science is what we like to say, but it's this concept that, with continued physical therapy and kind of providing different kinds of stimuluses to the body and the spinal cord, you can facilitate recovery. These 5 components you see here, FES, so functional electrical stimulation, locomotor training, weight bearing, mass practice, and task-specific training, those are just kind of concepts. You can achieve each of those things utilizing multiple different interventions. I'm going to skip this for sake of time. So FES, functional electrical stimulation. So functional electrical stimulation is basically just applying some kind of a functional task while using electrical stimulation. There's multiple different kinds of FES. So you have transcutaneous stimulation, you have neuromuscular electrical stimulation, and then you have your basic TENS unit. So depending what your goal is, depends on what kind of electrical stimulation you're going to utilize. So a lot of the time, if your goal is motor recovery or something like that, you're going to put it directly over the spinal cord, right? So that's going to be transcutaneous. You have neuromuscular electrical stimulation, like let's say you're trying to preserve muscle bulk, that you're going to put, like, let's say on your quadriceps to preserve the bulk and the lean muscle that's going to be there. So that's an important distinction to make. In terms of how does this work to facilitate motor recovery, it's actually a PM&R board question. So this will impact your CPG. It's your central pattern generator, usually common in your lower thoracic / upper lumbar cord. And it's basically kind of this reflexive area of your spinal cord where the impulses don't really go all the way up to your brain. They just kind of synapse there locally, and that's kind of how you get repetitive locomotion in terms of your legs moving, right? So left foot, right foot, left foot, right foot. You don't necessarily have to have that brain impulse, that electrical impulse go all the way up to your brain every time. It just goes right to your central pattern generator. The other thing too to consider with this is that it's being utilized not just for motor recovery, but for neurogenic bowel and bladder, for example. So there's you can use electrical stimulation. You can have devices surgically implanted that allow you to control your bowel or your bladder. Acute intermittent hypoxia. This is super cool. So a lot of you guys, I know anyone that goes into PM&R, I'm sure you've heard about the FLAME trial with stroke patients where you're looking to increase serotonin and that leads to improved motor recovery after a stroke. that's kind of what I think of when I think of AIH. So basically what it is you are deliberately inducing a hypoxic environment. So ideally between 82 to 85% O2 is inhaled. You can see here in the diagram, it's basically the patient can just sit there in their wheelchair. And theoretically, that will increase levels of serotonin, and that serotonin has shown to have the results are kind of varied, but you'll at least have some kind of improved motor function acutely. And now there's some studies that show that you can actually have sustained, retained motor recovery with using things like this regularly. And at least where I did my elective rotation, they basically kind of like anytime someone's coming in for an outpatient therapy session, they start the patient like kind of like in their warm-up phase. They start them with this as almost like a primer for the therapy sessions. So very cool to kind of see. Blood flow restriction therapy. So this is something that like athletes commonly utilize, but it's also now being used in spinal cord injury patients. The reason why that they're doing this is that with influencing the amount of blood flow coming to a muscle, you can actually influence the how much lean muscle mass is retained. So you can basically have you induce an ischemic state. Because of that, you have higher muscle tension, which means you have more muscle contraction. And because of that, you're more likely to retain muscle and not lose it after an injury. I'll explain why I keep kind of harping on this retaining lean muscle versus gaining adipose tissue in one of the slides coming up, but that's an important concept to remember in spinal cord injury patients. Aquatic therapy, I'll be completely honest with you, this is something I kind of initially read of and I shrugged it right off. I didn't really think there could be much to it. After reading a lot more about it, it's actually going to be extremely beneficial, not just for spinal cord injury patients, but really anyone that has some kind of neurological impairment. These 5 things listed here are kind of the hypothesized beneficial properties of water that can lead to some kind of improved function for patients. And a lot of the times, like for example, with spasticity, just the temperature of the water, if it's set at a very specific temperature, if it's warmer, it'll allow the muscles to relax. That can kind of help that overactive reflex arc be a little bit less overreactive, which means you now have less spasticity. And why is that important? Again, a lot of the spasticity medications that are out there, they can be very sedating. They can affect your blood pressure. In spinal cord patients, we already know they have bad blood pressure at baseline, right? So that's one less medication you have where that can influence your blood pressure and potentially prevent someone from participating in therapy. Exoskeletons. So this is another thing I think that like many things in spinal cord injury, like electrical stimulation, for example, we know that these things help, but to be completely honest with you, we have absolutely no idea how to utilize them. So we know that exoskeletons can help with, for example, preserving bone mass. We know that they can maybe help with reducing spasticity, but we have no idea how to dose them in terms of using them as an intervention. And what I mean by that is how many times does somebody need to use an exoskeleton and for how long before they start to see some kind of a benefit, right? Because the idea is that you're using an exoskeleton to, reduce spasticity or increase bone density, which means they take less spasticity medications. They have to take, less bisphosphonates or something like that to retain bone density. So we know that they can help a lot of these domains, but we don't know necessarily how to dose them. And I think that's the question that research really needs to answer moving forward in the next couple of years. The other thing I'll say is that they are starting to reimburse for this now. Insurance companies are as of the last couple of months. So not fully, but they're at least getting to the point where, people are willing to pay 10 to 20 grand out of pocket. Insurance will pay the other 70 to 80K for somebody to own their own exoskeleton unit. And I think that for somebody to really kind of see reductions in secondary impairments and really see a benefit in terms of quality of life, these are things that, coming in 3 days a week to use for a 20-minute session, you're not going to get a lot out of it. But if I can wake up every day and I can use this consistently on my own, I think that's when you're going to start to see a lot of improvement using things like this. Role of EMG, NCS. So next couple slides, I'm just going to kind of highlight some things why I think spinal cord injury is very interesting, not just from a physiatry point of view, but I think pursuing it for a career-wise. So EMG, NCS are used very commonly in spinal cord injury. The reason for that is you can evaluate for diaphragmatic pacing versus phrenic nerve pacing. You can see here in the photo. So you have the phrenic nerves coming down. You have this device that can either be surgically implanted or it can be an external device that you just wear, where you have the cuffs that kind of come around the phrenic nerve, and they basically stimulate the phrenic nerve and allow someone to cough or allow them to speak. And again, if you remember, people with a cervical spinal cord injury may have trouble clearing their secretions or at high risk for pneumonia. This device basically kind of alleviates that. So you can use EMG, for example, to make sure that those nerve pathways are still intact after a spinal cord injury. The other reason why I think it's very important is that for somebody who's paraplegic, for example, which again is going to be one of the most common kinds of spinal cord injury, your shoulders and your upper body are going to be your new legs, right? So you're going to be transferring a lot more. You're going to be pushing down on your arms. You're going to be pulling a lot more, pushing a lot more with your arms. You're going to be more prone to developing upper extremity over entrapment, nerve entrapment issues with that. So using an EMG to be able to sort something out from like a cubital tunnel syndrome versus a carpal tunnel syndrome is very important, because again, the treatment for that is very different. And carpal tunnel syndrome, while it might not sound like a huge deal, for somebody who needs to transfer from their wheelchair to a bed, if every time they put their wrist down, they have this insane pain in their wrist, you want to identify that, because that can be very limiting for somebody who really relies on their hands and their shoulders. Ultrasound, I know everybody in PM&R wants to get into ultrasound now, so this is just kind of an alternative that you can use in terms of evaluating somebody for upper extremity overuse stuff versus an EMG. You can actually use it to evaluate for like diaphragmatic excursion. You can see here, there's standardized values that exist out there in terms of how much a diaphragm needs to contract and relax. And that can basically tell you if somebody can breathe on their own. And this was super cool. We did this on the inpatient side when I was at Kennedy Krieger in terms of like evaluating little kids who are like on vents and stuff like that. And this evaluates basically the likelihood of someone getting off of a vent. And that's a huge deal, because if you've ever seen somebody with a vent, which I don't think I have a slide on that, but it's a very big, bulky device that you have to come around. And if that thing stops working, you can't breathe, you die. So being able to wean someone off of those can be a very life-changing experience. And for an adult, that could be the difference between, living in a long-term care facility the rest of their life and them going home and living with their loved ones. So kind of a cool way to utilize EMG and ultrasound just to, improve function after a spinal cord injury. Neurogenic obesity. So this is something you will not read in textbooks. This is one of the things that really kind of excites me about spinal cord injury. So this is basically kind of discovered by Dr. David Gator. So he was a chair at the University of Miami. He unfortunately passed away. He basically found that after a spinal cord injury, you have, because of disuse atrophy, lack of weight bearing, below your level of injury, all of your lean muscle will basically atrophy away. Not only does the muscle atrophy away, though, it's actually replaced by adipose tissue. And at first we're like, okay, what's the big deal? We just have less lean muscle, more adipose tissue. But as you can see here in the super detailed diagram, what this basically means is that this higher levels of adipose tissue means higher chronic systemic inflammation. And again, kind of like how you have blood pressure problems after a spinal cord injury, you have a higher level of chronic inflammation in spinal cord injury. Now, that can be a problem for multiple reasons. So if I have a patient who has a spinal cord injury and they're on an inpatient setting and I think that they have some kind of infection going on, and I check an ESR-CRP, it's going to be higher, right? And that's a problem, because that can be very misleading in terms of, do they have an infection? Do they not have an infection? Now, you also factor in the fact that their blood pressure sits a little bit lower. So now I have somebody who has a low blood pressure and they have higher inflammatory markers. You're starting to kind of look septic, right? And that's the difference between sending someone out for a full evaluation where they're missing therapy in this critical window of having functional recovery after a spinal cord injury, versus just realizing that that's just how spinal cord injury is. But anyway, they have higher chronic inflammation. And the higher your chronic inflammation, you basically have accelerated what we call neurogenic aging. And what that means is that you're going to be more likely to have cells die. You're going to be more likely to develop cardiac disease and all these other secondary complications after a spinal cord injury. And again, why is this important? If you're getting a spinal cord injury at 40 years old and you survive this initial spinal cord injury, you want to have the highest level of functioning that you can after the spinal cord injury for the rest of your life. The last thing you want to do is start adding in all these cardiac medications to, diuretics, which are going to influence your blood pressure. Just pill burden, having to take all these pills every day, right? So you want to mitigate these changes in body composition. And it's kind of growing into the literature now in terms of where this is. And this isn't something that's really going to be tested during, if you do a PM&R residency, you're not going to get a ton of questions on this. This is going to be more like spinal cord injury fellowship stuff. But I think it's an important thing to realize why we want to preserve lean muscle. And that concept of chronic inflammation doesn't just live in the realm of spinal cord injury. It lives for everybody. So if you're a perfectly healthy adult, theoretically, if you have a higher lean body mass and less adipose tissue, you have less inflammation, you're going to theoretically be healthier. You're going to develop less secondary health complications. And the last thing I'll touch on with this, So muscle fiber type. So if you guys remember from like basic med school stuff, you have type 1 muscle fibers, type 2 muscle fibers, right? You have this change in muscle fiber type with spinal cord injury. So everything below that level of injury, you have a change in type 1 muscle fibers changing into type 2 muscle fibers. And why is that an issue? Well, if you guys remember, those muscle fiber types utilize very, very different pathways of metabolism. And those different pathways influence how your body metabolizes substrates. So how I metabolize carbohydrates and lipids is going to be different if I have more type 2 fibers versus type 1 fibers. And this is where that concept of using electrical stimulation to preserve lean muscle mass is important, because you'll preserve more type 1 muscle fibers, which means you'll be able to reduce chronic inflammation, which means that you will reduce all these secondary health complications and have a higher quality of life. So that's kind of my spiel on neurogenic obesity, and I'll get off my soapbox after that. And then lastly, what I'll do is just why I think spinal cord injury medicine is so cool. Again, I think that it highlights a lot of what is really cool about PM&R, right? I think everybody that goes into PM&R, regardless of what they tell you to write in your personal statement, you want to help people, right? I think that spinal cord injury medicine really allows you to do that. So you're not just treating patients, but you're also treating their families. Their families are going to help them obviously a lot living and adapting to their new life. For anyone that likes procedural stuff, hopefully I've showed you that there's a lot of opportunity for that in terms of doing EMGs. You get a lot of upper extremity like joint injections in terms of shoulder injections, elbow injections, wrist injections, baclofen pump refills, which is nice because now you're also managing spasticity and you're seeing patients every 3 months. And it's a procedure that you do in the office where you basically stick a needle into someone's abdomen with this little pump that lives in their, a little like reservoir pump that lives in their abdomen, and you're refilling that. I think that it blends obviously anatomy, MSK, and neuro very well together, just having to know the different myotones and dermatomes. And for me, that's at least like what I really enjoyed about med school. I wasn't really very keen on all the GI stuff, and especially the nephrology stuff. That was a nightmare for me. To get into academic medicine, I think pursuing a fellowship in this is very important, just because, again, we know a lot of these interventions work, but we don't know how to use them. So I think that coming up with better ways to study these interventions, preferably in animal models like rodents, and then transitioning that into like people living with spinal cord injuries is going to be very important. And then the other thing too that I at least I think is cool is again, you do need to know a lot of basic medical knowledge for spinal cord injury patient or spinal cord injury medicine. A lot of the fellowships that are out there, you're becoming a PCP for these people with spinal cord injury. So not only are you managing the pain, spasticity, and all the spinal cord injury specific stuff, but you're managing their blood pressure medications, you're managing their insulin, you're doing all these other things, but you're not doing it too much, hopefully. You're doing just enough where, you're not feeling like you're a hospitalist, and you're not feeling like an internal medicine or a family medicine doctor. And you still kind of get that nice job of being a specialist physician in terms of managing all these other complications. Just some resources for you guys. I think that this one I have here, so you guys got Spotify, the American Spinal Injury Association. They have this really, really awesome podcast. They have basically what they do is they take research articles and they have 2 different podcasts per research article. So they have a community perspectives, but then they also have like a academic or research perspective. So they'll take the same article, they'll kind of dissect it from like an academic medicine point of view and what does this mean for like a clinician, but then they'll also look at it from the community perspective in terms of how does this impact everyday life for someone with a spinal cord injury. And that's very interesting, right? Because I think that if we're not doing stuff to better quality of life and help our patients, and what's really the point of doing it? So again, I think understanding why we do certain things is important, and this podcast does a great job, I think, of doing that. And then lastly, up top, you can see here the Miami Project to Cure Paralysis. So that's based down in Miami. That's what Dr. David Gator was in charge of. They had this whole awesome lecture series online. If you just literally YouTube Miami Project to Cure Paralysis lecture series, they'll have like a lecture on everything you can think of. He's got a ton of stuff on neurogenic obesity if you want to learn more about that. And he goes into basically everything about spinal cord injury. It's really easy to watch. Just hop on a treadmill, you get your steps in every day and you just listen to it. So some of my references, these are just some pictures we have of our program. They're like a year old. I don't have any of the new ones. But yeah, that's kind of all I've got for you guys. And if you guys have any questions, feel free to ask away.
Amazing, Mike. Thank you so much. That was so thorough. Very, very helpful. Does anybody have any questions? I didn't see any in the chat. You can either put it in the chat and I can read it, or you can just unmute and ask. I guess if nobody has a question, I was wondering, the neurogenic obesity stuff is super interesting. And I think PM&R doctors are like, it's a very holistic field, and there's like a lot of, I feel like application for like lifestyle medicine and different like kind of motivational interviewing, like to change a patient's habits. What role have you seen for things like that, like healthy eating, adaptive sports, for SCI care?
So adaptive sports has kind of always been there. I think that like the healthy eating, for example, it sounds very simple, right? It's kind of like very intuitive. Like you would think it would be done. It kind of would have already been done, but it's not. And that's what's like kind of crazy to me. And the other thing to consider in terms of like nutrition and metabolism and spinal cord injury is that anytime you're gaining or losing weight, right? It's thermodynamics, right? So more energy in, less energy out means that you're going to gain weight, right? And think about that in terms of spinal cord injury patients. So you are taking people who are probably eating the same amount of food that they were eating prior to their spinal cord injury. They're moving significantly less, which means they're burning less energy, which means they're going to be putting on weight. And it's like, what's the big deal? We're just putting on weight. But kind of as I briefly talked about, you now have this higher inflammatory cascade because of all that weight, which actually has very, very significant implications on your health. So there's actually not a ton of research that's out there. And that group in Miami is really the only group that is doing research on this stuff. And it's very like basic stuff if you read it. Gary Farkas is another guy that does a lot of research in that realm, particularly with nutrition. He was actually up here at Hershey for a while. But he's down there in Miami now. He's a PhD. Mark Nash, who's going to be retiring soon. He's actually, I think he got like a huge major award today from Asia just because of the research he did do in terms of all his metabolic research. He's another one that kind of, they basically identified this pathological pathway after spinal cord injury and potential interventions as to how to change it, but we don't know how to use those interventions. And I guess kind of the second part of your question, like what are some things we can do to kind of instill these like habits? I think that's where acute rehab is so important. And I think that's where understanding why we do things and telling patients why we do things is important, because everyone after a spinal cord injury wants to walk and they want to get back to where their life was prior to their injury. And by all means, that should 100% be the goal, but that does not always happen. And I think that acute rehab is a time to kind of instill these are the things we need to do until that does or does not happen. And you need to, the sooner you can get someone to buy in as to why they need to do something in a very regimented setting, like acute rehab, once they go home in a more volatile environment where they're not able to kind of, where they have more control over things that they can and can't do and not having a therapist come and saying like, hey, you need to go to therapy right now. They're going to be more likely to retain those habits once you ingrain that to them as, during acute inpatient rehab. So not only is it, getting them to understand why they're doing their bowel program every day at a certain time and how they need to do it, but it's ensuring that they continue to follow up with their physicians, because a bowel program, for example, and how someone changes their exercise habits and things like that, that's not something that you do at once and it's done, right? So like it's something you're going to continually change over time. And that's why it's important that you ingrain that, I think, into people and have them really buy in during acute rehab and give them that education. So I think acute inpatient rehab isn't just, exercises and figuring out a couple of medical conditions. It's really providing patient education as to why we're doing certain things and why it's important to continue to do those things.
Great, thank you so much. Jesus has a question. If you don't mind me asking, how much SCI exposure do you get at your home program,
So
like at
we get a
Tower?
decent amount. Yeah. So I think that it's your spinal cord injury experience, and not just spinal cord injury, but I think like brain injury, for example, is going to vary very much depending on where you do your residency. And I think that that's fair because you have if you guys aren't familiar with like the model systems of care, right? So there are certain centers across the country that are model systems. And anyone that has a spinal cord injury wants to go to a model system. What I can tell you is that we are not a model system. And I can tell you, my very first spinal cord patient, who I still talk to this day, and he lives here locally, he was like a workers' comp injury. So I had him for 2 months at rehab. And when he was done at rehab, workers' comp paid to fly him to one of these big fancy spinal cord injury centers down at in Emory, or Shepherd Center down in Emory. They did the same things that we did, and the reason that they're doing that is because, again, they have access to these interventions. They don't know how to use them. We have access to some of them, but we don't have access to all of them. And I think that it's very hard to have insurance companies buy in to let you use these interventions during acute rehab as well as chronic rehab after, if you don't have literature that proves that they're efficacious. So a lot of these like big spinal cord centers, they do obviously get exposure to all this stuff, but it's experimental. And like patients think that it's helping them, and you want it to help them, and you hope it does help them. And I know it does help them to an extent. So that's the distinguish between like model systems and non-model systems. We get decent exposure here. I mean, ideally, I would like more. I did an elective in spinal cord injury just because, to be honest with you, I didn't want to go through the match. There is a match for fellowships. It's very non-competitive for spinal cord injury. There's only like 8 applicants in the country last year for 40 spots. So if you get in the right situation, you can sign a contract before the match and not have to go through that. And that's kind of where I was trying to feel stuff out. But in terms of here at Tower, your intern year, we're categorical. So you'll see a lot of very acute spinal cord injury because we're a level 1 trauma center, which was a very, very cool experience because you'll get a lot of patients on vents. We don't take patients on vents at our acute rehab. They have to go somewhere else, unfortunately. But we do take normal spinal cord patients. Our services here, I think they're 12 beds each on the inpatient side. I would probably say, so spinal cord injury comes in waves. Justin, I think when you were with us, I don't think we actually really had any. But like right now, we've got like 4, like solid 4, and there's 2 more on the consult list, and they're very like high level complete spinal cords. The one thing we do get is we got a lot of outpatient spinal cords here, which is very interesting because again, you have people that go to these model systems places for a very short period of time, and then they come back to their local area, which is much smaller. And we actually have a decent amount here in Reading. So we see a lot on our outpatient side, not just for chronic spinal cord care, but we also do things like their spasticity management and things like that. So the inpatient side is probably not the strongest. The outpatient side, I would actually say we have a pretty robust outpatient population.
All right. And then Maha's asking, kind of going off that, how did you go about selecting programs that aligned with what you were looking at, such as SCI, like for when you applied for PM&R?
For like residencies, you're saying?
Maha, is that kind of what you meant? Like when he was applying for PM&R in general,
Yeah.
programs that had better SCI versus worse?
So, yeah. So, I mean, I kind of did things backwards with PM&R. So like I knew spinal cord initially. I think that I wouldn't advise people to do that. I think that first of all, I think PM&R is getting so competitive now. You kind of have to go where you match. You kind of like don't have a choice. I mean, again, I knew I wanted spinal cord, so I kind of selectively ranked the spinal cord places I thought were highest at the top of my list. And that's kind of how I went about it. But PM&R is honestly so competitive that you almost like can't do that. The other thing I'll say too is like if you want to do a fellowship in something like spinal cord injury or brain injury medicine, you're gonna get it coming out of PM&R. Like there's 40 spots for spinal cord injury in the country. I kid you not, there was 7 or 8 applicants last year, like 7 or 8 in the country. Like that's kind of insane. And you really get to pick what you're gonna do. But what I will say, if you want to do spinal cord injury medicine, so let's say you do go this fellowship route. I think that doing a fellowship in spinal cord injury medicine and practicing exclusively spinal cord injury medicine kind of pigeonholes you into certain places where you can work. And that's something that I kind of didn't think about until where I'm at right now. So I truly do not want to see anything outside of spinal cord injury patients. Like I only want to see spinal cord injury patients. I'd like to see some stroke patients, and I'm cool with like seeing some brain injury patients, but like I do not want to see anything else. It's just kind of what I knew going into residency. And unfortunately, if that's kind of the mindset you have to be willing to go to a place that has a fellowship, that you get exposure to enough of spinal cord injury or enough of brain injury, but then you also have to be willing to go work somewhere that has that. So if you want to only see spinal cord injury patients, like your big hubs are going to a place like UW, or you're going to USF in Tampa, or Miami in Florida. Like those are kind of, or Baylor, or Shirley Ryan, even maybe. But again, like you could theoretically do a spinal cord injury fellowship in one place and then have to move somewhere after. So those are just things to consider when you guys are kind of exploring this stuff. And I'm older, so I'm kind of just, I'm trying to plant roots. I don't really want to have to move anymore. So just things to consider. And you don't really think about that when you're like a med student.
Thank you.
Yeah.
I'm not sure if you kind of touched upon it right now, but why do you think spinal cord injury is less competitive?
I think just no one wants to do it. I think kind of like how Jesus said, like people just, you don't really get a lot of exposure to it. I think unless you're going to a residency program that's affiliated with a model system, you're only going to see a couple chords, right? Like you're going to see some, and hopefully that's enough to be like, hey, like this is what I want to do. Again, I did things backwards. I worked in research before I went to med school, and I worked specifically in PM&R research, and I did a lot of stuff in spinal cord injury. So I had a very good exposure to it before that. I felt that despite that, I think that, coming to Tower, you still obviously want to, it's one thing thinking you want to do something, but then when you kind of get into it, it's like, do I really want to do this? The experience I had through my intern year here and just on the acute rehab side, those were enough to say, I could really see myself doing this. And it's fun. So I too, like, I liked the idea of like family medicine and internal medicine. We get to see patients all the time. But I don't like having to deal with a lot of those problems. I think that spinal cord injury medicine allows you to kind of see a very unique patient population where they want to help themselves. And I'm not saying that there's anything wrong with any of those other aspects of medicine, but for me, like one thing that I knew going into medicine and one thing that was 100% apparent to me after my intern year was and maybe it's wrong to say, but I don't want to help patients that don't want to help themselves. And you guys will see this in your intern year on medicine. You'll get the recurrent patients that come in who have CHF and they don't want to take their Lasix, and they have COPD, but they're still smoking. And like, yes, those people need care. They deserve the best care possible, but I personally don't want to do that. And I think that spinal cord injury medicine kind of allows you to work with a very motivated patient population. And again, I'm not, trying to down talk any of the other specialties or patients that have recurrent CHF exacerbations. But for me, I just know like I didn't want to deal with that. And I think that spinal cord injury medicine is a very, very unique patient population.
Mike, do you think that kind of what you just said about like the patient populations being very motivated, do you think that applies to like all the specialties of PM&R, or do you think it's very like specific to SCI?
I mean, I think it applies not just to I think anything in medicine, not just PM&R, right? But internal medicine. You're gonna have tons of CHF patients who don't want to get CHF exacerbations, and they're gonna take their Lasix. But I think that spinal cord injury people, I think that people living with spinal cord injury, I think that it's such an abrupt and fast change to your life. Like I had a gentleman, he was a couple years older than me. He was in his late 30s, and he had a work-related injury. And one day he was living life and he's doing things, and the next day he can't use his hands, and his significant other she's helping him go to the bathroom. She's helping him get up and out of bed. She's helping him learn how to walk. And I think that, you'll have some patients who they will initially, maybe they can't get medically stable enough to the point where they can participate in enough of therapy to get better. But you'll have patients who will really kind of like try to fight through it. And this one gentleman, for example, he's a C5 Asia A, because he was on a vent, I remember. And he sent me a video, literally, it was like a week ago. He left rehab and he was standing, but his spasticity was so bad, like his scissoring with his legs was so bad. Like, I mean, he couldn't like walk. Like he was standing with a walker, but his therapist was almost like kind of like dragging him forward. And then a year later, the guy's got a baclofen pump now. He's getting Botox injections. He's got his blood pressure stuff figured out. He was walking for a full minute with distant supervision with a walker. And that's really, really cool to see. So I think that, again, I think spinal cord injury patients, I think that anyone in medicine, whether it's CHF exacerbation, COPD, spinal cord injury, stroke, I think that you're going to have varying levels of how motivated the patient is. But I think that acute rehab is nice because patients do have that abrupt change, which is sad, but it also allows you as a resident, especially as a resident, because attendings won't want to do that kind of stuff, spend time with the patient and tell them why this is important, and they buy in and they get to do that. And to me, that's really cool because you see people who they come into rehab, in a wheelchair, and sometimes they walk out, and that's cool. It doesn't happen all the time, but when it does happen, it's very rewarding to see.
For sure. Does anyone else I just had one more quick one I wanted to touch on. Just kind of just to take advantage of your experience and your expertise. Uh you mentioned PM&R being so competitive. What advice can you give us? I know there's a lot that we could talk about, but what would be the advice that you kind of most wish that you would have as either applying this year or like in the next couple of years?
It's a good question. Um, I will tell you guys, as like someone who was a med student, like I was like full, gunner status. Like I remember I was reading Cucurullo going into like my audition rotations. Um, I think the willingness to learn is important. I think that no matter where you want to go, you'll find out that you will wind up going where you fit in the best. That's what I ultimately realized with kind of my match process. I had been to Tower as a med student for a little bit just to like visit, and this place felt really good to me. I really jived with the residents here. I really liked Dr. Crozier. I really liked the attendings here, and it felt very natural. I would like there was other places I necessarily might have thought of were better programs, and I thought that I did very. I mean, I thought I did very well during like my rotations there, for example. And I had attendings tell me that, but I knew I didn't fit in there. So I think that getting as much exposure with programs is important, and that I think that finding a place where you fit in is very important. And I think that, don't fake it, like be yourself, because places can really kind of pick up on that stuff. And the flip side of that too, I think that if you, let's say, you go through your process, your match process, when that time comes and you wind up somewhere you don't want to be, I think that the mature thing to do, the mature stance on that is to realize, I didn't fit in there. This place didn't think I fit in there, and it's probably a good thing because residency is tough. It's 4 years, no matter how easy or hard your residency is, like you're not going to want to do everything that PM&R has to offer, and I think that you have to go somewhere where you fit in well and you jive well with the people, because there's going to be some good days and some bad days. But at the end of the day, everyone's kind of, you're all on the same team and you want to do the best thing moving forward. So I think showing up to rotations, being energetic, and showing that you've read up on stuff and being prepared is important. I think that being yourself is important, and just being genuine. Like if there's something that interests you, by all means, go the extra mile to write the case report somewhere, or go the extra mile to go to the support group, or go to the therapy sessions. But don't do it just to do it and like to fake it, because places will pick up on that. And I think that that is what writes off a lot of med students. And it's a lot easier. I will say, like kind of being on the other side of it now, it is a lot easier to pick up on that stuff when you're sitting on this side than when you're the med student. Because I remember being in your guys' shoes and thinking I knew everything. And I was like, oh man, like I got to do this, I got to do this, I got to do this. And this is how they're going to interpret it. I can tell you right now that that's not how programs think about stuff. And every program looks at stuff differently. What some programs might value, other programs might like not care about at all. So just things to consider. And that's why don't stress yourself out, be yourself, kind of enjoy the process. You'll kind of, you'll wind up where you're supposed to be. And I know that's super frustrating to hear, because, you kind of can't really impact where you go, but that's kind of unfortunately that's kind of the reality of the situation. Sorry, I don't have any good advice for that.
No, that's all great. All right. Well, Mike, thank you so much. That was a great lecture, very thorough. Um, yeah, unless don't have any more questions, I don't want to keep you. Thank you for your time, Mike. Appreciate it.
For the Instagram for our fellowship, could we take a photo of everyone if everyone could put on their screens really quickly? And I'll just send the post-didactic survey. Thank you, Mike, again for all of the wonderful information you shared today. So I'll just share the post-didactic survey and then I'll take a screenshot. So I'll count down from 3. So 1, 2, 3. Okay. Thank you, everyone. Have a great night. Thanks again, Mike.
Thanks, guys. Have a good one.
Thank you.
Thank you.